So, hello, everybody. Hi, how do you prefer Virginia or Ginny?
Do you know what? Virginia or V is most common, but to be
Virginia.
honest, I
Okay.
go by anything.
Okay,
Anything that
fantastic.
sounds vaguely right, I'm there.
Fabulous. Okay, so we've got Virginia, who's here to talk to us about our pelvic health. This is Virginia has been so gracious coming back to the Vibrant Midlife community to share this vital information with us because we had a failed attempt, my fault, in June. So it's a pleasure to have you here, Virginia. I'm sure our women, because I've had women say, "Where is that recording?" I said, "We're on it. We will get to it." She's a very busy lady. So yeah, it's. I think I'll say take it away. Just introduce yourself to our
Thank
community, and then just
you.
give us give us all your wisdom and all your gems.
Thank you so much for having me, and thank you so much for inviting me because I know it's a really precious community that you guys facilitate. So it's a pleasure to be with you, and it's a pleasure to speak to you about vibrant midlife in relation to your pelvic health and optimizing your pelvic health in your vibrant midlife. So, my name's Virginia. I'm a pelvic health physiotherapist. So, a physiotherapist that's given up on the necks, back, and shoulders that most people think of when they think of as physio. And I now work in pelvic health, predominantly in gynecology clinics. But when we think about pelvic health, if you think about what sits within the pelvis, we cover all the different compartments that are sometimes divided up in medicine. So you've got your bladder at the front, your gynecological organs in the middle, and your bowel at the back. And we know there's a complex interplay between all of them, and particularly in our midlife, when some of those hormonal changes can really have a significant impact. So, I wanted to talk to you about some of the things that we see in midlife in particular, so that you're aware of things to watch out for, so that you know what you can get help for and how you can get help if you need it, but also so that we can be preempting some of this stuff so that you're informed and empowered to know what we can get cracking with at any stage in your life so that you can really optimize your midlife pelvic health. And don't worry about questions and things. My emails, my socials are all at the end as well. So we'll probably have a bit of a discussion as we go, any questions at the end. But also, if this brings up some questions that are particularly relevant to you or you want to get in touch with me, absolutely please do. That's why we're here to support each other. So, what is pelvic health is where I'm going to start. But then we'll move on to pelvic floor function and dysfunction in particular. And one of the areas of midlife that I want to focus on is genito-urinary syndrome of the menopause, because you guys are experts in menopause. I won't go through lots of the physiology of menopause, but what I'd like to talk about is the impact on our vulvas, our bladders, our pelvic health, because I know that's not always spoken about when we're having a coffee with friends. Thinking about how pelvic health physio and other online resources and other medical colleagues might be able to help with that, and signposting you to some really useful free resources so that we can empower ourselves, knowing about ourselves and knowing how we can get on top of any symptoms that might appear. So my little disclosures, first of all, half the week I'm an NHS team lead in pelvic health physiotherapy down here in Southampton. The other half of the week, I co-founded the Pelvic Pain Network, a group of professionals that specifically work to support women with pelvic pain. I'm on the education subcommittee of the POGP, which is our specialist registration group for physios that work in pelvic health. And I'll be mentioning some of their free resources. And they've got a really good Find a Physio app as well, if you're looking for someone close to where you are. And I'm just finished some research work with Brunel University London, where I did my master's looking at improving pathways of care in pelvic health. So what is pelvic health? You may have previously heard my group called Women's Health Physiotherapists. And the reason why we've moved towards pelvic health is to be more inclusive because we see men's health, women's health, but also to really highlight the fact that anything that's going on inside the pelvis or around the pelvis, because we need to treat ourselves as a whole person holistically, there is an avenue for us. Sometimes I think historically in the NHS in particular, we've often said this is for urologists, this is for urogynecologists, this is for colorectals, and women sit on 5 different waiting lists for 5 different things. Whereas actually the interplay is so constant from adolescent puberty, childbearing years, menopause, and beyond. We want to, as a group of professionals, increasingly look at pelvic health as a whole. So you might have friends, family who might talk about urinary leakage, bowel leakage, pelvic organ prolapse, difficulties opening their bowels, pelvic girdle pain in pregnancy, an overactive bladder that disturbs you during the day or over the night, sexual pain and dysfunction. And all of these things come into the remit of a pelvic health physiotherapist. And what I'm going to show you next are some anatomical pictures. Because when we think about women getting the help they need, something that comes up again and again is struggling to find the language to describe their symptoms and what they're struggling with. Because we know that actually, how do you Google something if you don't even know what to put in the search box? And how can you make the most of that 6-minute appointment with your GP? Often it starts by finding the vocabulary to say, actually, what's different to a few years ago? Where does it feel different? And how is it impacting you? So just to let you know, I'm going to show you some anatomical pictures. So this picture of the external female genitalia largely shows us the vulva. So if we ever had any sex ed growing up, unfortunately, it will largely have just described the vagina when it's talking about female genitalia. Whereas actually, the vagina is just the inside of that canal. So sometimes we might compare it to talking about your face, your mouth, and your throat. So actually, all of the external genitalia that you can broadly see in this picture is called the vulva. So often people might talk about itches, sore patches, dryness. If it's on the outside here, we're talking about your vulva. And that's a great way to start the conversation with your GP, your nurse, your physio, describing symptoms on the outside. Vulval pain, common symptom that we see in clinic. Then the area that's much closer to the vaginal entrance inside the inner labia is called the vestibule. And that's more similar here to around the entrance to my mouth here. And you'll see the tissue type changes. If you're examining yourself, you'll see that it's a slightly different color, slightly different texture, hair-free, a bit like the inside of your mouth compared to the outside of your cheek. So the outside genitalia, we're talking about the vulva. That inner boundary around the entrance to the vagina, we're talking about the vestibule, inside those inner labia. And then the vagina goes further inside, that inside tube. And that's an important distinction, I think, that we're not often told about when we're exploring or learning about sexual function, sexual health, and pelvic health, because this is not all, of course, about sexual function, but actually owning our anatomy, owning our experience, and actually having a look. Something that we're very aware of is that there's fantastic awareness increasingly about self-checking your breasts. But often women don't ever have a look at their vulva. So if they ever do go to the doctor about a funny area of change, a mole, the doctor will often say, when did it change? How long has it been like this? And often we don't know. So actually, I would encourage you that if you're in a really healthy cycle of doing monthly breast checks, actually adding that monthly vulva check can be really useful to spot any changes, particularly as some of those are more common around our midlife. Then if we're thinking about the pelvic floor muscles, there are 2 layers, one that sits deeper inside and one that sits more superficially on the outside. And this picture here is looking into the bowl of your pelvis at the deep layers of your pelvic floor. If you look at the picture, you can see it almost looks like a sleepy or a sad dog with the kind of eye creases and then down towards its nose. But what we're looking at here is really how broad those muscles are. They're not a small group of muscles. Everything red there you can see is part of your pelvic floor. So it really is that basket at the bottom of your pelvis, supporting your pelvic organs, supporting how you move, supporting how you breathe to some extent through your abdomen. So actually, it's not this little muscle that we should forget about. It really covers a big area. And you can see there it attaches to the pubic bone at the front, back to the tailbone at the back. So it has an important part in bladder function, sexual function, bowel function, and supporting all those pelvic organs. Then more superficially, just beneath the skin, you've got these superficial pelvic floor muscles, which are slimmer, longer, and they sit around the bony rim, almost like anchors or the guy ropes on a tent to secure everything. And if you're someone who notices pain or spasm around the vaginal entrance, these are unfortunately often the culprits, because if you look at where they sit, they actually wrap around the entrance there. So they're sometimes considered the gatekeepers to your urethra, your vagina, and your bowel. So if you're someone who struggles to pass urine, struggles to open your bowels, struggles for your examinations or sexual function, sometimes it's these superficial muscles that we want to be checking out. And these pictures will come out to you as well with this presentation, so you can have a little look. So what happens in the perimenopause and menopause? Now, you guys are gurus in this area. I know that this is something that you guys as a community have covered a lot before. So again, I'm going to bring it back to our pelvic health. So we know the vagina on the inside, the vulva on the outside, the urethra, that tube up to your bladder, the bladder itself, and the pelvic floor muscles are all really responsive to that reduction in estrogen. And that can happen right at the beginning of perimenopause, not just when your periods stop. And that's an important thing for us to remember. We know that the tissues in that area become thinner. We know they become less flexible and elastic. We know that less lubrication is produced, and this can often result in women describing vulva vagina dryness, almost like a fragility of the tissues where they feel like their tissues often feel less robust because the blood supply is not quite so good there as well. The ligaments and muscles can unfortunately become a bit less supported, which is why some women will describe that heaviness underneath or a vaginal bulge or symptoms of pelvic organ prolapse. And we know that the pH of the vagina changes, and that change can affect the balance between good and bad bacteria. So we know that that changes your vaginal microbiome. You might have heard about women being more prone to urinary tract infections and vaginal infections during this time of your life. So these symptoms can unfortunately sometimes go not unnoticed by the individual, but sometimes unnoticed by society because we may not be talking about these things. So what we want to say in this safe space is that these symptoms are common, but not normal. So they're common. We know it affects a huge amount of us, but they're not normal to the point where you think, I've got to put up with that. Because actually, there are treatments available, and they're the kind of things that actually your GP, your gynecologist, your pelvic health physio talks about every single day. So it's not embarrassing to us, and we want to make sure women are well supported with these symptoms. And there it is. Genito-urinary syndrome of the menopause affects over 50% of women. And you'll see that the name there, genito-urinary, it alludes to the fact that this is not just a vaginal symptom. This is the whole genito-urinary tract, the genital tract, thinking of vagina, vulva, but also urinary tract, bladder and urethra. And again, if we think about those recurrent urinary tract infections, bladder leakage, urgency, we know that this spectrum of conditions comes at the same time in our midlife. And that's why it's got a specific name, so that we can make sure there's better research into this, better information being shared about this. So it might have used to have been called things that were not very beautiful, like vaginal atrophy. But actually, genito-urinary syndrome of the menopause is what your GPs will now call it, gynecologists, pelvic health physios, and that's what I'll be sharing information about today. So because it can affect all of those different areas, let's just make sure that I'm being really clear about what those symptoms might look like to you, so that again, you know how to communicate that and get the help you might need. So how it might affect the bladder is that it might become urgency. Whereas previously you could do your daily tasks, knowing you'll go to the loo at some point, with those changes in midlife around the menopause, we particularly know that urinary urgency becomes more common. That can result in urinary incontinence, or you may still get there in time, but it becomes quite disruptive, daytime or nighttime. It's considered roughly normal for most women to go 0 to 1 times at night to pass urine. More than that, we know it can really disrupt your sleep, and there are things we can do to help with that. Recurrent urinary tract infections, and sometimes difficulty passing urine. Again, symptoms of genito-urinary syndrome of the menopause that treatment is available for. The vulva and the vagina, you might notice a loss of that tissue fullness. Anatomically, you might well see some changes in shape in the mirror, but these should be gradual. Anything fast or dramatic, we would again get you to get checked out. And it might present as pain, itching, dryness, or that feeling of heaviness suggestive of pelvic organ prolapse. And not only do we want you to be able to self-examine to know what's normal for you, but these are things that should get checked out with your doctor because we want to make sure it's nothing else that needs a specific line of treatment. Unfortunately, we do know that vulval cancer exists, and it's not one of the best well-known gynecological cancers. So again, any changes in your anatomy there, we want you to get checked out. And sexual function, this can present as painful sex, reduced clitoral sensitivity, or reduced libido. So why is a pelvic health physio talking about this? The reason I'm talking about this is because this is an everyday conversation in clinic. Our role as a pelvic health physio is to help you reclaim a happy bladder, happy bowels, happy vulva, happy sex, and look at pain management tips and tricks that if you have got longer term pain, how do we help you feel good again? How do we help you get on top of that pain? And making sure that you feel supported with a pain flare-up toolkit, because we know that bumps in the road happen, and we want to make sure that you feel empowered not just now, but for the future as well. So, in the time we've got today, where should we begin? Because it probably feels like I'm about to send you off reading lots of journal papers or something, but we're going to bring it down to hopefully some manageable, easy everyday tips, and then we can always explore more if you'd like to get in contact. So I'm going to suggest that we've got 5 priorities to optimize your pelvic health in midlife. And the first thing I would say, because so many women don't, is if you recognize the symptoms we're talking about today, get in touch with your GP. Say you've heard something about genito-urinary syndrome with the menopause and you'd like to talk about some symptoms in particular. That's because we want you to get help, but it's also because we don't want to go anything else missed. We don't want to go without picking up on some other things that might need more urgent care, because there are some symptoms where we need to do an ultrasound or something else to check there's nothing else going on. So the 5 steps that I'm going to talk to you about today, one is hopefully the quickest and the easier. Let's get in a habit of checking your vulva so you know if anything changes and what's different to you. I'm then going to talk about a little kind of introductory bits for some happy bladder habits, some happy bowel habits, where pelvic floor exercises might fit in for you, and how you might be able to get in contact with a pelvic health physio to support you more as an individual with your individual needs. So this is a booklet that the Pelvic Pain Network and I have written on our website because we want information to be available to everyone. You listening, your friends, your family. I almost want to get, a bit evangelical, spreading the word that this is out there and we want to make sure we get help for this. So this is on our website, but what I'll do is I'll just share the PDFs of any documents I mentioned today in with this recording, so it just comes as one bundle for you to keep whenever you want it. So thinking about a happy vulva, we've got this booklet which describes tips and tricks to get vulval pain relief. The most important thing is, though, is that pain doesn't go unspoken. If you've got pain in your vulva, again, that's common but not normal. So we want to make sure you have a look and you get a healthcare professional to have a look to make sure we're not missing any skin conditions or changes that need more urgent care. Then we want to actually think about skincare. Unfortunately, in the market at the moment, there are all these intimate health products. Absolutely not what we want on your skin. We want to be kind to that area of skin, particularly inside the vestibule and the vulva. They are self-cleaning. So if you have a favorite shower gel that doesn't irritate your skin and you want to use it on the outside, in between your kind of thigh creases and areas that might get sweaty, absolutely do. But inside the vestibule and the vulva, we don't want to be using any products in there. Likewise, we want to be kind to that skin, maybe actually just thinking again about what underwear you're wearing. If you do tend to struggle with vulval irritation, we often want to go back to white, undyed cotton underwear to make sure that it's a breathable fabric, particularly in this temperature, that you're not getting that hot irritation. We also know that unfortunately some of the sanitary pads or incontinence products can irritate your skin. So again, if you're struggling with urinary incontinence, we want to get you treated for that, not just to help your bladder, but so that your skin hasn't got those pads up against it all the time. And then what some women consider kind of magic is happy, healthy lubricants. Because your natural lubrication reduces in midlife with the perimenopause and menopause, your day-to-day lubricant might be slightly less, but also lubrication on arousal. So it's not to do with how aroused you are with your partner or any change in dynamics there. It's a local physiological change. So it's a healthy conversation to have, whether it be activity on your own or activity with a partner, that actually a perfume-free, glitter-free lubricant can definitely help with vulval or vaginal discomfort, as long as it's one of those low irritation ones. And we've got more information about that in that booklet for you to have a little read about. Again, we've got some information about a happy bladder. And the thing that can be frustrating is that this can often be new for a lot of women. Women I speak to might have said, do you know what? Actually, I've never had a problem. This is brand new for me. And I wasn't sure if it was an infection, but actually now seems to be the new normal. So if there is a new symptom, we always want to rule out an infection. If it persists, again, we need to check with the GP to rule out anything else. Sometimes you might need a camera inside to have a look at if, particularly if there's any bleeding. But if it's an urgent sensation to pass urine during the day or the night, actually there are things that we can do to retrain that bladder. The other thing that some women mention is that their bladder was a bit wobbly in pregnancy or postpartum, and they felt like they just about got away with it. But then those hormonal changes in midlife bring that extra wobble. So you might already have known that you might have felt like you had what some women call a weaker bladder or a weaker pelvic floor, but particularly this urgency and leakage can definitely present in midlife. Broadly speaking, if you're leaking urine, there are two types. Stress incontinence is to do with pressure in your tummy. So if we think about leakage with coughing, sneezing, or jumping, that's stress incontinence caused by pressure going up in your tummy that your pelvic floor can't respond to as fully as we would want. The other type of incontinence is urinary urge incontinence, where you have this urgency to get to the loo in time, but unfortunately you don't get there in time. And some women can describe very strong triggers for that, like putting the key in the door or seeing the toilet. When your brain gets excited, your nervous system gets excited, and all the messages say, go, and we don't have time to stop it. So again, thinking about the language you can use, if you recognize either of those things, makes it easier to find the information you might need and to get the help you might need. Because there's a really good evidence base that we can actually get 70% of women 70% better with those symptoms. So we don't want you to suffer in silence. Get that call with the GP, get the care that you might need. So some little things that might generally help as little kind of quick wins. Aiming to drink about 1.5 litres to 2 litres of water a day. We know that some women really restrict their fluid when their bladder's misbehaving because they think, oh, if I drink less, there'll be less going on and I'll feel better. But unfortunately, we know that concentrated urine can actually irritate your bladder too. Think about it like Ribena that you haven't diluted fully. So actually getting into some of these healthy patterns gently, if you're someone who's only drinking tiny amounts at the moment, you want to build that up gradually. And you would want to consider limiting your caffeine, your carbonated drinks, and your alcohol. Now, some people are more responsive to caffeine than others, so it's often a good idea just to set yourself a challenge of going low caffeine for a week and seeing if it makes a difference for you. It really often does. And then consider limiting your fluid intake to sips of water only in the 2 hours before bed. If you're like me, a lot of us, if you're busy during the day, don't practice that good fluid intake across the day, and you think, I'll catch up in the evening. I've got to hit my markers. And then it's probably not surprising that when you lie down at night, that's the first chance your kidneys have had to catch up with all that fluid intake. So actually drinking throughout the day, drinking plenty of fluid with your evening meal, but really restricting that fluid intake before bed can help with some of that nighttime waking. But there's more information in that booklet for you if that's of interest. Now, happy bowels, happy bowels. It almost grieves me to say that the men have had this right for a while, ladies. So, sometimes we think about men going to the loo as if they're reading the newspaper in there for hours. Actually, that forwards position is a really good poo position. So if you're someone who struggles to open your bowels, actually in a forward sitting position, With your feet elevated, if you're someone who's still got small relatives, children or grandchildren around, if you've got a little stool for them to use, or you've got a basket where you put your loo rolls, something to put under your feet so that you can then lean forwards and rest your arms on your knees, is a really nice position for your bowels to open. It can reduce constipation and straining, and therefore it reduces that extra strain on your pelvic floor, reduces hemorrhoids, reduces pain. So a nice comfortable poo position is a nice quick win. The other thing that of course will make it easier is the poo consistency. Because if you have got hard poos, it's really difficult to have a comfortable poo, whatever your position. So if you look at this funny scale on the left here, we broadly aim for a type 4 poo in that picture, which looks like a smooth sausage. Unfortunately, we know it can of course vary, but if you're getting those hard rabbit poo pellets or the hard type 1 and 2s, it's going to be really hard to open your bowels comfortably. So even before we think about more fancy physio tips and tricks, actually starting off by thinking, how can I tweak my fluid intake? How can I tweak my diet or my routine so that I know I'm more likely to get those comfortable poos, will help everything else before you even have to think about anything more complex with your bowels. The tricky thing is that we know the other type of poo, the loose poos, can unfortunately make you more urgent. And I'm sure we can all relate to if you've ever had an upset tummy, it feels very much more urgent to get to the loo in time. If that's the odd occasion, that's hopefully not too disruptive to your life. But if it's persistently at one of those trickier ends, you may want to talk to the pharmacist or GP about a way that you can aim for slightly happier poos, because we know that constipation and straining makes you more likely to have bladder difficulties, makes you more likely to have prolapse difficulties. So having happy bowels can help the rest of your pelvic health, not just your bowel health. Now, you probably are not surprised that if you've got a physio on here, I'm going to make a mention of pelvic floor muscle exercises. Now, it's one of those things where I think we all know we should do it, but actually finding out how to do it well, if you're doing it right, and how to fit it into your daily routine is more commonly what we hear about in clinic. So the reason why we want to practice pelvic floor contractions is so that we don't lose that muscle. And you probably thought about it in other discussions that in midlife, perimenopause and menopause, our muscle bulk does change throughout our body. So even separate to the other genito-urinary syndrome of the menopause changes, we know that if we don't use it, we lose our muscle mass in perimenopause and midlife. So just like any other muscle, repetition of contractions is how we keep these muscles working. The way to think about doing a pelvic floor muscle squeeze, if you haven't had any time to look into it further, is actually to start at your back passage first. Because if you look at this picture in the middle, you can see that that hammock we were talking about earlier supports the bladder, the uterus and gynecological organs, and your bowel at the back. So we want to lift that whole hammock there. And the way we want to do it, in sitting, not when you're out and stressed, somewhere comfortable and at peace to start with while you get the rhythm, is a lift and a squeeze, as if you're stopping yourself passing wind and then let go again. That's how we're going to start. The next time, what I'm going to get you to do is to imagine you're doing a zip up from the back passage to the front passage, almost like you're doing a zip along the seam of your jeans. It'll look a bit banana shaped from the back passage, under and up. So it's not lifting straight up like you're going up in a lift. It's lifting forwards and ups like you're going up on an escalator. So what I'm going to ask you to do this time for a full lift is a lift and a squeeze, as if you're stopping yourself passing wind, closing around the vagina and stopping yourself passing water, and then let go again. Again, you're going to draw up, lift and a squeeze from the back to the front, and let go again. Now, if Bucky and I were doing this together now, the test would be that we shouldn't be able to know that each other is doing it. If she can see me bouncing up and down, then I'm using my big hip muscles and my glute muscles, not my pelvic floor. It should be that she can only see a little concentrating face while I'm thinking about it. And the way we ask you to do it is short squeezes to train the fast response, but also some holding on squeezes to work the stamina and the endurance of those muscles. And as you can see here, we've got some posters and information about that again, I've got the links for. And what we would like to do is, if you're symptomatic, encourage you to do it 3 times a day, get referred, get supported for that. If you're looking at doing it more from a maintenance point of view, thinking about tying it in with something like brushing your teeth, morning and evening every day, so that in the same way as we brush our teeth to keep on top of all of that, you can then know that you're keeping on top of your pelvic floor strength and control at the same time. You'll see at the bottom of that poster, it mentions different positions. And that's because the more gravity we get involved, the harder it is for the muscles. So you might want to start doing it in sitting, like I just showed you. But actually, if you're someone who gets leakage when you're standing up and sneezing, you're going to want to train the muscles in standing so that then you get more benefit when you really need them. And if you are someone who gets leakage before sneezing, you might find it helpful to actually consciously tell your muscles to squeeze before you cough and sneeze, rather than relying on them to do it automatically. So actually, if you feel a sneeze coming or a cough coming, lift and squeeze and then cough, and you might well feel a little bit more supported underneath. So this QR code works to take you to the POGP website. These are the National Organisation for Pelvic Health Physiotherapists. They've got some fantastic resources on pelvic floor muscle exercises that we've just spoken through. That's where you can see those posters and that advice and guidance in a little bit more detail. Some other resources that are really helpful to make sure that we get the right information out there. The British Menopause Society and Women's Health Concern have got a specific document talking about urogenital problems. So again, this is something that we would want your practice nurses, your GPs to be well versed on already. But if you actually want to read up a bit more as well from some of this formal guidance, so then you're empowered when you go and have these conversations and you know about possible next steps, this is a nice, trusted, centralized resource to have a little look at if you'd like to. Some other resources, so the POGP I've mentioned, the Pelvic Pain Network is where you'll find me, and we've got those online documents that I'll attach when we share this recording. The Vulval Pain Society, specifically for that vulvodynia, that pain on the outside, really nice, and that's a organization run and led by women with lived experience. So it's quite nice for that peer community support as well as clinical guidance. The Menopause Charity and the British Menopause Society that I've just shared. So what I would suggest we do is that I move on to the next slide so that you've got all my contact details, because please do not worry about emailing, using socials, however you would like to get in contact, because I think some women commonly want to ask a couple of questions before they dive into seeking help. And if I can help remove barriers to getting the right care at the right time, that's exactly what I'm here for. But otherwise, what I'll do is see if Bucky and I wanted to go through any questions or discussions while we're together now.
Oh my God, Virginia, that was just, it was amazing. It was pitched perfectly, clear, to the point, and yeah, just very, very informative. I mean, I know, you know when you know stuff, but when it's explained in a way, you just think this is, and I just believe I know this will be so helpful for a lot of women. I wrote down a couple of things.
Hmm.
So one of the things I wrote down was on our website. So when you talk about the GSM symptoms of the menopause,
Hmm.
we have symptom trackers, because what
Yes.
can be helpful for women is for them to actually track their symptoms, so that when they go to have a
Hmm.
conversation with a healthcare professional, they, to your point, having an informed conversation, because they're going to ask what exactly is going on. Now, what I loved was when you talked about and you explained all of the different areas and having the right vocabulary because sometimes, oh, I've just got an itch down below, we use all of these funny things, and that to a clinician is like, tell me what exactly, they're needing a bit more specific, to be a bit more specific. So I'm hoping that women that would have gone through this, they're familiar with some of the terminology of particular
Hmm.
areas. They can use the symptom tracker
Yes.
from our website. It's vibrantmidlife.com, and begin to then start, if this is an area of concern, begin to start to track that, so that when they have that conversation, that was one thing I
Mm.
wrote down. The other thing I wanted to say was, on the NHS at the moment, are you aware what's the kind of waiting time to see a pelvic health physician, for example?
That's a great question. So it varies at the moment because some areas of the country have self-referral and
Mm-hmm.
some others have different pathways to care.
I see.
So it is normally
Mm,
always best to start at your GP practice for a couple
okay.
of reasons.
Uh-huh.
One is because we want to make sure that we're not missing anything else.
Mm-hmm.
So
Mm-hmm.
there are some conditions like lichen sclerosis and
Mm-hmm.
other conditions that might give you vulval symptoms that we want to make sure you've got an appropriate examination with a
Mm-hmm.
healthcare practitioner to make sure you don't need to go through any of the urgent pathways to get urgent care. So we
Mm-hmm.
want to make sure that you bring your symptoms to someone like your GP to make sure we're talking about the same things,
Yes.
and then they can help us get the right care.
Okay.
Now, it broadly tends to be that you might fall under a urogynecology pathway if
Okay.
you've got bladder symptoms or vulvovaginal symptoms.
Mm-hmm.
And what is really, really helpful
Mm.
is if you and your GP are really clear about your concerns, whether
Yes.
that be stress urinary incontinence,
Yeah.
urinary urge incontinence, or
Mm-hmm.
pelvic organ prolapse,
Mm-hmm.
when the consultants get those referrals into a urogyne team, like the team I work with in the NHS,
Mm-hmm.
they can triage them straight to the right
Very
practitioner.
quickly. Okay.
Whereas, unfortunately, sometimes what happens is if the description of the symptoms is a bit ambiguous,
Yes.
there will be quite a long wait to go to the consultant-led clinic first,
Mm-hmm.
and then you go and see the pelvic health physios. Then you almost got the two waits. Whereas actually, if there's a nice clear description in the referral, often the consultants can triage you straight to the right nurse, the right physio to help get that going. So I'm aware that often it's the consultant waits that are often the longest at the moment. So
Mm-hmm.
if we can make sure it's really clear in the referral, then often you can see a pelvic health physio a little bit quicker. In my service and a few other services, I know that the wait to see the consultant can vary from 6 months to a year,
Mm-hmm.
which is why we want to make sure that we've got some of these resources online so that
Yes.
women can access them and get cracking while they're on those waits. But what we would
Yes.
always say
Mm.
is that first appointment
Mm.
only gets closer if you go to the GP first.
Fab.
So I tease my mother because she'll tell me about her achy shoulder and say, "Oh, I'm not going to go, it'll take forever." And I say, "But it'll take even longer if you never
If you
go."
don't go.
Exactly.
Yeah, and I think that's the importance of women onboarding this sort of clear information and getting this information, so that they
Mm,
know when they've got the symptoms, they know the terminology, they know their bodies. I always say us women know our bodies better than anybody else, and can go
exactly.
and advocate for themselves and say, you know what, this is what I'm experiencing. I've read up, I've done this, I'm tracking my
Yeah.
symptoms, and I would like a referral, so yeah, that's really, really, thank you for that.
And I'm happy to be a bit of a go-between as well, because it's quite common that friends, family, other networks will reach out to me and say, "Well, I'm in Yorkshire. What do
Mm,
you know about the system up there?"
exactly.
And because
Yeah,
the
yeah, yeah.
POGP is quite a small community, I can
Fabulous.
normally find out about the NHS services and the private services in that area. Because some
Great
women will
stuff.
get that GP referral in,
Mm,
and then when they know the wait time, they've got that referral in for their ongoing care. And then
hmm.
they might see one of our private colleagues for a couple of sessions to get the ball rolling while
Just
they're
get
waiting.
going. Yeah,
And then we cover all
fabulous.
the options.
Great stuff. That's really, really helpful. I think the other thing I wrote down was aspects around, you talked about skincare.
Hmm.
So I'm familiar with the lubricants situation, but when
Mm,
we talk about skincare, so when we talk about, you talked about, cotton, and we talked
mhm,
about, using sanitary products. I guess
mm,
that brings me on to, because I had a talk with another lady who talked about her sanitary products, and
mm,
some of the sanitary products now are evolving to have use a lot more natural elements within them, again just to minimize that irritation. So that might be something that women want to consider. But also, when we talk about washes,
mm.
um, what would a
So,
pelvic, okay, yeah, go on. You got you
there's in the vulval pain booklet that we've got on our website that we'll share
Mm,
with this,
mm,
we've got some of the quick wins, which is hopefully the stuff that actually, you know, whoever watches this webinar tomorrow could start
mm,
straight away.
mm-hmm,
Sometimes, if the easy steps don't
mm,
give you the relief you want,
mm-hmm.
we'll sometimes work with vulval dermatologists. So these
Okay.
are specialists
Mm,
where actually they will sometimes recommend a
mm,
mixture of topical agents, a bit
mm-hmm,
like we would take our child to the doctor for their
mm-hmm,
eczema if it doesn't
mm-hmm,
get better,
mm-hmm, mm-hmm.
because they will actually sometimes use some of the things that we consider barrier creams
Mm,
as the washes on the outside, so
yeah.
that we're not doing anything that depletes the tissues.
Mm-hmm,
But
mm-hmm.
then there are sometimes then prescribed
Yeah.
combinations
Okay,
that,
cool.
a bit like with pain relief, you start with the thing with the lowest risk profile and work your
Mm-hmm.
way up. You're absolutely right. We avoid the intimate washers.
Yeah,
We avoid the lubricants that are not pH friendly and have
absolutely. Yeah,
irritants, colors, and
yeah,
flavors. We
yeah.
consider underwear, and we
Mm,
consider actually if your estrogen there is fully optimized. I'm
mm,
not a prescriber. I
mm,
work with my GP and consultant colleagues,
mm-hmm.
and a lot of them talk about the power of vaginal estrogens
Yes,
for local tissue quality. And
fabulous.
that's something, again, that we know that even if you're inserting the cream or the little pessary inside the vagina,
Mm-hmm.
actually has widespread
It
impact
just, yeah,
on the
absolutely.
genito-urinary
Yeah,
symptoms.
yeah.
So that's something that I didn't talk about at length there because I'm not a prescriber, but something that the majority of our women with genito-urinary syndrome of the menopause report really strong benefit from.
Yeah, thank you so much. And we can find that, the quick wins within those booklets, because I was going to ask that they are downloadable from your website. So
Yeah, they're free PDFs there for you to have a
fabulous.
look at.
I think the other thing I just wrote down was around, when you were talking around the bowel,
Hmm.
and just pinning that back to diet and aspects around
Hmm.
fiber intake and all of
Hmm.
that kind of aspect to help with but I mean, so yes, you talked about the drinking.
Hmm.
That's quite key, and it can be counterintuitive, because you're thinking, I want my bladder, I don't want to drink so much, but to your point, concentrated urine can cause it,
Hmm.
wreak its own havoc. So, and
Yeah.
then it's just for women to just be aware of, fiber helps move things along, and just so yeah, I
Yeah,
think
and
it.
it's quite a strong feature now in what people often talk about as prehab and rehab.
Mm,
If we think about how people go in for joint replacements, and
mm,
they'll often have surgical school or prehab advice and
mm,
education before going into their op, knowing
mm,
that it'll optimize their rehab afterwards.
mm,
And actually thinking about the number of our women in midlife that have procedures and surgeries in their
yeah,
tummy,
yeah,
whether that be a hysterectomy or anything else, we
mm,
know that actually one of our superpowers can be optimizing your bowels before a hospital stay. Because we know that being out of your normal routine, the
absolutely, it goes,
painkillers,
yeah,
anything in your
yeah,
tummy,
yeah,
we often think about optimizing your bowel on the other side, but if it's not fresh new information and you've already experimented and found out what suits you,
mm.
that can actually be a superpower going into the recovery of any hospital stay for any procedures in your tummy as well. So exactly, you're right. Food, diet, exercise, and routine. Because any of us who've flown or traveled or stayed with in-laws,
Go on
and
holiday,
it changed your
everything's
routine.
messed up. Everything's messed up. And I think I just had the one final question, Ginny, just because. So for a woman that's not there yet, she thinks everything's going tickety 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 boo. Give me three top tips for looking after her pelvic health. From a maintenance perspective.
Perfect. So, three top tips if we're looking forwards is
Mm,
actually going to start straight away with what we're just talking about now is bowels. Because
mm,
we know that chronic constipation and straining can
mm-hmm,
predispose you to more pelvic floor symptoms later in life.
mm-hmm,
So even if you are hormonally tickly boo right now,
mm-hmm.
getting a happy, healthy bowel routine, absolutely one of your superpowers.
Fabulous.
The thing to then think about is pelvic floor maintenance.
Mm-hmm,
So that's not saying you have to do it every minute of your life. Think
mm-hmm,
about it akin to brushing your teeth.
mm-hmm,
Finding that nice routine of short contractions and endurance contractions,
mm-hmm.
morning and evening, with a nice relaxation in between each squeeze. Because in my
Fabulous.
work, predominantly in pelvic pain, we know that some people can actually get an overactive pelvic floor if they're in pain. So
Yeah.
making sure that you contract and relax
Please.
beautifully your
Yeah.
pelvic floor. And then thirdly, I would say use this time to really understand your normal now. So
Mm-hmm.
actually, like we said, have a good look so that if there is a change, you
Mm-hmm.
notice that change.
Mm-hmm.
Because life is so busy.
Yeah.
Women, we juggle 100 different things.
Mm-hmm.
Really, a vulval examination is probably right at the bottom of your list. But I
Yes.
would say that it doesn't need to be every day. But if we could think about, there's some great online campaigns to do a breast check on the first of every month.
Mm-hmm.
If we could do a breast check and a vulval exam on the first of every month, actually, not only would it help the pelvic health stuff I see, it would really help you get early care for any serious conditions of the vulva as well, if we're thinking about vulval cancer and other conditions.
And for those of us who are married, we might want to get someone else to have a look. You never know where that might lead. All right, I shall let me press stop. Virginia, this has been amazing. It's really, really, I mean, I've learned so much, myself, even just myself. I mean, you know things, they're latent, but just having this conversation has just been so enriching. So I'm going to stop recording.